Welcome to Myo360, the podcast, where we'll delve into all topics related to myofunctional therapy, including airway health, snoring, sleep apnea, TMJ, tongue ties, thumb sucking, and even bedwetting. As a myofunctional therapist, sleep coach, functional breathing instructor, and formal dental hygienist, I'm sharing stories and tips to help you identify if myofunctional therapy is right for you and how it can help improve your overall health. Visit the show notes and take our quiz. Is myofunctional therapy right for me? Are you ready to feel better? Find the quiz to see how myofunctional therapy can help you and your family live your best life. Hello, this is Becca Rose of Myo360, Holistic Solutions for Snoring, TMJ, Better Breathing, and Better Sleep. Thanks for coming back for another episode. Today, I'm very honored to have a guest with us. He's going to be talking about orthodontics and airway. So please welcome Dr. Just to the podcast. A little bit about him. He is a dedicated orthodontist with a passion for changing people's lives via their smile. He's a recent graduate of Marquette University's orthodontic program, where he just received his board certification in orthodontics and completed his master's thesis on skeletal growth and development of malocclusions. Dr. Just has joined Just Orthodontics, which is located in Sheboygan and Manitowoc, Wisconsin, and he will be practicing orthodontist in those offices. So thank you for joining me today, Dr. Just. It's great to have you here.
Absolutely. Thank you for having me.
How did you get into orthodontics? What piqued your interest in that career?
My dad and grandpa were both orthodontists, but I was really fascinated in science in undergrad and really wanted to get into dental school and go the dentistry route. While I was in dental school, I had a few patients that had a lot of occlusal disease and occlusal wear. And just looking at their cases and seeing how something like this could happen over 30 or 40 years, it just made me realize how important the occlusion is of teeth and how fascinating orthodontics was and how that can really create a stable foundational occlusion for a whole lifetime. So I think seeing these extreme cases of tooth wear and realizing that, hey, there is a specialty that can help these people. And not only are we changing lives with creating an aesthetic smile, we're creating a stable foundational occlusion that will hopefully serve them their whole lives. So once I realized that, hey, that's also the profession that my dad's in, that really made me super excited about going into orthodontics and realizing that it's not just creating a nice smile. There's way more to it than just getting the teeth all lined up. So after I learned all of that, I was like, okay, let's go into orthodontics. This is super exciting. It took a lot of dental school learning to get to that point to see how amazing orthodontics is. So I'm glad I'm here and I'm excited to start my career.
Yeah, it's exciting to have you as part of the local orthodontic team, both in Sheboygan and Manitowoc. So talk a little bit about the occlusion issues for people who don't know what that means. Like, what is occlusion? What kind of things were you noticing with occlusion? And then what did you realize that, hey, there's something else to this, not just making straight teeth?
Right. The first time that I became really aware of how severe things can be is I had a patient that was having really bad headaches and neck pain. And we were doing all sorts of tests on her and checking occlusion, checking her teeth if there's any sensitivity, taking x-rays. We were putting her on corticosteroids to see if there was some inflammation in her neck that we couldn't really detect. And then it turned out that we just had to make a couple occlusal adjustments to the teeth, and all of a sudden all of her pain went away. And it was amazing to see that just a small change in occlusion can make such a big difference on their lives. After seeing all of the wear on people's teeth as they're getting older, I just think that having the teeth in a stable occlusion when they're young and just setting them up for a long life of not wearing on their teeth, that's the best way that we can go. So that's what really made me excited about orthodontics.
I actually just had that same experience a couple weeks ago. I had a crown that needed to be replaced from a few years back, and I was chewing some months, and I'm like, I just feel like something's going to break. Like when I chew on that side, like I feel like something's just going to break off. And I'm a dental hygienist by trade. So I'm like, what's going on with my teeth? And all it took was a little bit of adjusting the way my teeth were fitting together, the occlusion. And I'm like, oh, that feels great now. So it does make a big difference. Well, what do you notice with people with occlusal wear in kids? Are you noticing a lot of grinding patterns in children when they
Absolutely. I
come
mean,
to see you?
we do see a lot of occlusal wear, and unfortunately, a lot of times we're just saying they'll grow out of it, and that's usually what people are just taught to say. But I think there is things that we can do to help prevent that. And I know that the enamel of baby teeth is a little bit thinner, so it does wear more easily. But I think there's something more to the fact that they are grinding their teeth, and that does mean that there's some stress going on. So I think that means that it needs to be treated in one way or another. And I know that working with you and hearing about what you do, that's a great supplement to what we can do orthodontically, is to also rely on myofunctional therapists to handle any tongue or breathing issues alongside of our orthodontic treatment.
I love that there's becoming more awareness in the dental field and the orthodontic field about the role that airway and myofunctional disorders are playing in the oral facial development, right from birth or even in utero. This process is already happening. And then what do those muscles in airway dysfunction, what do they do to the structure as it continues to develop? So it's interesting you bring that up, and I'm glad that you are looking for those things in your office, because back in, I think it was 2017, the American Dental Association suggested that dentists are in an ideal position to start screening for sleep related breathing issues. So there was a lot of encouragement for the dentists and other dental professionals to be looking at the medical history, the dental history, the structure. Are they snoring? Is there choking? Are they witnessing events of apneas and retrognathia, or the jaws being smaller than they should be? So I'm really glad that the Dental Association has brought that to light too. We still have a long way to go, of course, but at least that connection is starting to be put together. And we know from a functional standpoint, which is what I do, I work on the muscles that help support the function of the breathing, the snoring. We see often with our kiddos that grinding of teeth is usually, there's other factors, of course, but a lot of times is contributed to an airway issue at night, a breathing issue at night. Anytime that airway is occluded, whether they're breathing in too much and the throat muscles are maybe collapsing on themselves, or their tongue is falling into their throat, we see hyperextension of the neck. So, kids can breathe. Sometimes they jet their jaw forward, and that's where that grinding comes in. Some kids are wetting the bed. Some kids toss and turn like crazy, and it looks like a tornado went through their bed at night. So when that's happening, we're looking at airway, breathing. You're not breathing well at night. Your body has to do something. Your brain is in fight or flight. We're not breathing. We need to wake up. So how is that person waking up? Are they grinding their teeth? Are they wetting the bed? Are they very restless? So what's going on? And we can see a lot of those patterns in the mouth by looking at the teeth and the throat, also the symptoms that they're having: restlessness, snoring, behavioral concentration issues, and things like that. So thank you for looking for these things in your patients, because then you can help be part of their process to lifelong health.
And I think another part of waking up at night is people are being woken up because of like a fight or flight response. And having that over and over again at night, that's not healthy, and it can cause high blood pressure. And especially in young kids, they have a whole life to live ahead of them. So if they're already having these bad habits, if there's something that we can do early, any type of intervention, whether it's with myofunctional therapy or even orthodontic expansion, just making more room for the tongue and teeth to all fit in, I think that's something that we can do a great service, especially to our area. So I'm excited for the impact that we can have.
Yeah, and we definitely need a provider, especially an orthodontic provider in Sheboygan County and Manitowoc County that has some understanding of airway because there's not a lot of that around here. It's been slow to catch on in our area, but it's getting there. I say all the time, if you listen to this podcast, you have heard me say this over and over again. I am very cranky and not a happy person when I don't sleep well. And I'm an adult who can control myself. I know how to behave. But children, when they don't sleep well, they don't know how to have good manners and learn how to keep their outbursts down. So it's very highly recommended within the airway community that if there's behavioral problems or symptoms of ADHD or something similar, that a sleep disorder is ruled out because the symptoms and signs of sleep disordered breathing and behavioral issues are pretty much identical. So much of the time, it's just lack of sleep. They're exhausted and then act out because they don't know how to control their emotions yet and they're still young and learning. Yeah. And
Right.
then as we grow, those sleep deprived kids become adults like myself who was diagnosed with sleep apnea at age 28 and then wore a CPAP for 14 years. And then we get the high blood pressure. So when my sleep apnea was diagnosed, guess what? It was like around the same time in my late 20s. I was diagnosed with high blood pressure and I was taking high blood pressure pills. And then that cascade it's like downhill from there. So there's so much
Yeah.
we can catch when kids are
I think
young.
I think the best way to look at things is to try to do it the most natural way possible. And if kids aren't behaving correctly in school and they get diagnosed with ADHD and then they put them on a stimulant, then they're really not going to be able to sleep at night. So I think doing things the most natural way and trying to get our bodies into the most natural baseline that we can, I think that's the best way going forward. And to learn the most about the airway and myofunctional therapy, I'm actually taking the course on myofunctional therapy right now because I want to understand how to speak your language and understand how we can most benefit you on your treatment as well. So I think if I'm as educated as possible on the airway and myofunctional therapy, I think that'll help everyone out in the area.
And people will come from distances to see you when you have that knowledge and you can look at it from that whole body perspective with the airway involvement. Because again, there's handfuls of providers, but they're scattered. They're so far away from each other. And sometimes I'm referring people 2 hours away from here or further to connect with a doctor who has some knowledge of airway. And airway is also muscle. So it's nice that you understand too what effect the muscles have on the teeth. So can we switch gears a little bit and maybe talk a bit about what with your patients with like tongue thrusting or reverse swallows and what the muscle force does to the teeth and the shape of the jaw?
Absolutely. So, one of the sayings that we have in orthodontics is that form follows function. So, the form of the teeth is shaped by how things are functioning around them, which is the muscles. So, when we look at x rays, especially the Ceph analysis that we do, it's a sideways x ray, and you can get a good idea of how the muscles are shaping the jaw. So if a patient is very high angle and their mandibular plane angle is very steep, those patients usually have very weak muscles. And then when you look at other parts of their occlusion, you'll see, oh, their molars are super erupting because their biting force isn't enough to keep those teeth in position. And then that can form an open bite. And then that transforms into a longer facial profile. And then their chin is retrognathic. So all of these things, they start snowballing on each other. What my research, an analysis of a Ceph X-ray looking at the cranial base so that we can get a better idea at a young age on what kids might be having a more of a class 2 skeletal profile. And what we found is that there is quite a bit of difference that you can read on the cranial base. If it's more obtuse, that means that they might be more class 2 tendency, which could mean that they're at a higher probability of having sleep disorders in their life. So then we can jump in earlier and try to treat them to prevent that. So That's why I was excited about my research so that we could get a good head start on their treatment.
So, are you saying that this image, that Ceph X-ray, can almost, we can't ever predict the future, but you can tell by looking at it what might be a possible growth pattern for a child? Is that what you're saying?
Absolutely. This was something that I wanted to look at and just collect more data on it from the sample size that we had at my program. So we just typically take a bunch of measurements on those x-rays, and then we feed it into a program that reads out all of the numbers and angles and everything, and there's specific ones that we can look at, and then that can tell us if they're a high angle or if they have a class 2 tendency. And there's been research for the past 100 years looking at these x-rays, and there are orthodontists out there that predict exactly where things will grow, and then they'll take an x-ray 5 years from now and it'll almost be perfect. So we can predict where things will end up, and with artificial intelligence they'll get even better from here on out. So I think using orthodontics and the treatments we have, we can better treat these patients and be more proactive so that the teeth can be guided into their natural position, because that's going to be ultimately a lot more stable than if we're forcing teeth into their correct position when a patient is 13 or 14 years old and then they have to be wearing retainers their whole life. I'd rather have them come in early, guide the teeth into the correct position, so then they're stable there for their whole lives.
Yeah, and then on the functional side, we want the muscles to support that process. So after you do your work and you're guiding those teeth, then we want the tongue to be able to help with some of that retention. We don't want to have forward growth of the jaw continuing to happen. So yeah, you're right. We say that all the time too in our field, form follows function. That's Wolff's law, right?
Yeah.
That anytime you have a muscular force on a hard structure, it's going to guide how those things happen. Getting the muscles and the teeth and the jaw to all work together is going to absolutely lead to the best outcome, not just for those nice teeth, but sleep, snoring, sleep apnea, attention, just quality of life. So I'm super excited about this.
Yeah, and one thing that stuck out to me when I started taking the myofunctional therapy course was that you guys look at things more on a long-term basis, where orthodontic treatment is usually only 18 to 24 months. And we're talking about how the muscles are pulling on the periosteum of the bone, and that can reshape the bones over long periods of time. And a lot of the orthodontic studies are looking at, oh, if we wear a class 2 appliance for 2 years, does that change the shape of the mandible? And it's probably not. But if you're talking about a tongue function and how a swallowing pattern is for 30 years, can that have an impact on the shape of the bones? And I would say that it has to, because there's pictures of kickboxers that have stronger bones in their legs because they adapt to these things. So if your bones can adapt from a different swallowing pattern over a really long period of time, I think there's definitely changes that we can see, and making sure that our kids are swallowing and have the correct tongue posture early will definitely make orthodontics more stable long term.
Yeah, absolutely. It's amazing how patients find a myofunctional therapist and they've maybe have been in braces. I've had a couple that have come that were in braces as adults, and the orthodontist, they wore their elastics, they did everything they were supposed to do because they're adults and they knew better, but they still couldn't close the bite. And then the orthodontist got to thinking, okay, what's going on? Now, this was ortho that didn't have a lot of airway understanding, but notice like the tongue, you could see the tongue like poking out as that person was talking, had that little bit of a lispy, like their tongue pushing forward. And then I ended up getting connected with that person and we corrected their tongue thrust. And sometimes we need some help with that, with working with a provider who might do something called a tongue tie release. But we talk about that. That's a different conversation. But sometimes that's a part of the picture, not always.
Mhm.
But we got that, and this man was in his 40s. So we got that swallow corrected. And then the orthodontist was finally able to take the braces off his teeth confidently. And just a couple weeks ago, same thing with a woman in her 30s. She's had braces for 5 years and they're still an open bite. And the dentist actually dismissed her from the practice because there's nothing else he could do. And he just doesn't know. So sometimes people get upset and they're like, why isn't anyone telling me this? And it's just that they don't know. If they're not trained in it, they don't know. So I'm glad that there's more training out there and people are taking advantage of it. But what do you do in that kind of situation? If you have an adult who's been in braces as a child or a teenager and now they're in their 30s or 40s and they're coming to have braces again, how do you look at that situation?
Now I think just having more awareness of the different specialties around us that can help us out, because some of these issues we need to look at understanding the why behind what's happening. And if the teeth were straight in the past and now they're not, we need to understand what has changed. So understanding that there might be a tongue thrusting issue or a swallowing pattern issue, and then making sure that they're directed in the right directions before they're being treated is the best way to treat these patients. So I think if we can have a better understanding on how we can all benefit each other, I think that'll greater serve our patients. I was sending you a patient this past week. That was a situation where this is definitely a tongue thrusting issue. Let's make sure that they're seen by a myofunctional therapist and making sure that is corrected before we just put braces on and try to fix it ourselves, because at the end of the day, it's probably going to open back up afterwards because of their tongue thrusting issues. So we need to get that addressed first.
Yeah, absolutely agree. All right. So, what age do you typically start seeing patients?
We typically like to see patients when they have their permanent incisors, so usually around 7 years old. But if there's a major issue like cross bites in primary teeth that they might need some expansion in, that is something that should be addressed too, because we don't want the permanent teeth to be coming in a crossbite, because then that can prevent their growth potential in that area. So we don't want them to be trapped in a occlusion that's going to cause them to grow in a non-stable way. So if there's any huge red flags such as crossbites or any huge grinding patterns that might show that we need some expansion, then we'd like to see them earlier. But typically once the permanent teeth are in, at least the front two incisors, then we can use those to move things out of crossbite. So
Perfect.
usually around 7 years old, but sometimes younger if they need a little extra help.
Okay, good to know. I had a patient in my office and they were showing signs of the crossbite. What type of approach do you use in your office to help get those teeth expansion or ortho?
So we take measurements, we look at the molar widths, because sometimes we need expansion more in the anterior segments than the posterior. So we want to look at what areas do we need the expansion in. If they're in a crossbite and their molars are 28 millimeters away from each other, then we probably will use an expander to just jump that out of a crossbite. But if it looks like it's more of a tapered arch form and the molars are 35 millimeters apart, then we can use the braces to really expand the anterior segment to make enough room for the canines to come in. And we see a lot of times that the expansion is more needed in the anterior segment than in the back by the molars. So we look at it on a case by case basis. But either way, I know we were looking at some of our expansion photos, and we use these really easy expanders that are 3D printed that we can just bond right into the mouth so we don't have to fit bands, and they're super simple. We can just hold that there with retainers and make sure that everything is stable for at least 6 months and making sure that everything's growing correctly. I should probably add that for the expansion, we also like to look at the lower arch too, because a lot of times the lower arch is tipped in and that can restrict the airway too. So if we're doing expansion on the top, the bottom also needs to follow. So we can do that with braces, and we can upright those teeth so then the tongue has more room to function, and then we can straighten out any crowding in the anterior segment. So we typically, for young patients, if they have expansion issue or they need some expansion, we'll expand the upper arch, but then we'll also put braces on the lower arch to make sure that everything is upright, not just the top arch, because the top arch needs to occlude with the bottom arch. If the bottom arch isn't corrected, the top arch is probably going to go back to where it was, or the occlusion is going to be really uncomfortable for the patient.
Okay. I love that you bring that up because sometimes expansion isn't always needing a cemented in or bonded in expander. It's sometimes you just need to upright those teeth because, like you mentioned, you have the proper width from molar to molar, which indicates like how wide that jaw is. And we don't always need to have that traditional expansion. Making more tongue space sometimes is what's needed, correct? And then
Correct.
top and bottom teeth together so you have that good bite and that good occlusion to follow.
Hmm. Yeah, and then they have a nice stable occlusion when they're young, like 8, 9 years old. They have a good coordinated occlusion, not just an upper arch that's overexpanded, occluding on the buccal cusps of the lower teeth, and that's pushing those in a little bit more. We want everything to be well lined up so then the permanent teeth can be guided into their correct position. We have this amazing photo of a before and after from a phase 1 patient. We treated them when she was probably 7 or 8 years old. We came in, she had a lot of crowding in her lower teeth. We uprighted everything with expansion, got everything straight and lined up. We saw her back when she was 13 or 14. All of her permanent teeth had come in pretty much perfectly. She probably doesn't even need braces. And I asked her, I was like, do you still wear your retainer? Because we hadn't made a new retainer and she lost all of these teeth since then. And she said, no, I haven't worn it in 2 years. And her lower teeth were perfectly straight. So when we started treatment at 7 or 8 years old, she had a lot of crowding. But then because the bone is so malleable at a young age and we got those lined up, now her lower teeth are stable and those teeth will probably be stable her whole life. And so we totally corrected her problem early, and now she's going to have a nice stable smile for the rest of her life. And I
That's
know
amazing.
if we would have just straightened those teeth when she was 13 or 14 and just uncrowded all of that, it would have really wanted to relapse. So she would have had to been wearing retainers for her whole life. She was already not wearing retainers for 2 years and it's still straight. So I think that really shows that doing more preventative orthodontics and helping guide the teeth into the correct position, that's the best way to go because teeth are always going to want to go back to where they came in. So if we can guide them into the right position, then we're home free and hopefully we won't have to wear retainers their whole lives.
I always wonder what happened with myself because I've been a mouth breather my whole life. Always had such bad allergies and congestion. In my 20s or 30s, I had sinus surgeries and nose surgery to open everything up before I knew about any of this other part of the world. I had braces when I was like 15. I still had a retained baby canine over here, number 11. And so then they exposed it and they put the braces on, made room, exposed it, pulled it over slowly with a chain. And my teeth have stayed relatively straight. I have a little tiny bit of buckle or a little bit of crowding down here. It's pretty minimal. I'm like, how did my teeth stay so straight? Because I was in braces from age 15 to 17, and my tongue has been down my whole life, and I've been mouth breathing my whole life, and I didn't wear a retainer all that time, maybe for a year or two afterwards, like I was supposed to. I'm like, how did my teeth not move?
A lot of times it's because of what types of movements we had to do to the teeth. So if there was a lot of rotation, it's because of how the fibers are attached to the tooth that when it's rotating, we unrotate it, those fibers weren't rearranged. So they're always going to want to pull the tooth back into a rotated position. So there's actually different types of procedures where they make little incisions around the tooth to try to break up those fibers so that it'll be more stable. So that's something that orthodontists have done in the past, but the easiest way is to just have patients wear retainers. But I think if we have them come in earlier, and as they're developing and as their teeth are coming in, the teeth don't know any better other than the fact that they came into that correct position and they're going to stay there. So that's my ultimate goal as an orthodontist, is to try to get them into the most stable occlusion so that they can function good the rest of their lives.
So you're talking about the periodontal ligaments, right?
Yep.
Yeah. And like back in my case, my teeth weren't super rotated. They were pretty straight.
Mm-hmm.
So they didn't have to do a lot of work to rotate them and twist them back. They just had to make room for that and then pull everything together. So that's probably why I didn't have that force of those fibers trying to pull my teeth back to the position that they were in.
Yep.
That makes a lot of sense.
Probably exactly what it was. Yep. So you lucked
Okay.
out.
I know I did, but I've had what they call a CBCT scan. That's a 3D image. Even though my teeth are straight and I take my own measurement from molar to molar, I'm about 32-ish, which is still deficient, but isn't like extreme. It's manageable. We can work with that. But when you look at the CBCT scan, my real intermolar width is about 28 or 29. Even though I don't look super narrow, on my teeth are all lingually tipped. So in my case, I would probably be a good candidate to upright my teeth. I don't need real skeletal expansion, but I could improve my airway and my tongue space by uprooting my teeth in that case.
Yeah, absolutely. And it's amazing what we can do with brackets and wires. We showed you some of the before and after photos that you can upright teeth and probably create 5 to 6 millimeters of intermolar width just from uprighting and a little bit of expansion too. And especially in adults, that can make a big difference. You don't necessarily need skeletal expansion. You just need more room for your tongue. So if we can upright those teeth and create more room for your tongue, that's going to be more stable then as well. I think sometimes we can do quite a bit with brackets and wires. A lot of times braces can make a huge impact. And it would be really interesting to see what we could do with expansion with braces on a patient that does have a space issue and see how that impacts their myo.
Maybe I could be a test patient for you.
Yeah, absolutely.
Because I've been doing this for so long now, I can engage my tongue. So through myofunctional therapy, this is the other part too. You get that adult patient 5 or 6 potential millimeters of more tongue space without skeletal expansion. And then we're working on tone of the tongue, coordination, elevation, getting the tongue out of the airway, up into the roof of the mouth, staying with inside the teeth and not spilling out. So toning those muscles too is going to really just bring together that new potential tongue space that you might be creating for them. As I mentioned, we need this so badly. Our patients are looking for it. There's so much of a movement for trying to do things as naturally as possible and as least invasive as possible. So this is just the most logical, good starting step to guide growth and development of the teeth, the face, the whole oral facial complex in general. And working together, we can make those goals happen for our patients.
Absolutely.
That is our goal. And now for the fine print. The information presented in this podcast is for educational purposes only and should not be taken as medical advice. We recommend consulting with a qualified healthcare professional for any questions or concerns you may have regarding your specific health condition.